Thank you very much, Mort, and thank you very much for inviting me. It's really a pleasure to be back in Houston. Actually, I was here a couple of years after I left in 97, but then I haven't been here for 12 years. So I really have to say that something happened outside. Even the tram was not here when I was here last time. So it's really a pleasure to be here. I don't know whether I contributed that much to the ischemic preconditioning thing, but I was lucky to get into the thing at a time point where we had the possibility to translate from the experimental studies to the clinical studies, and I had the opportunities to do that because we had the infrastructure at our hospital to do it. Let me first introduce you to Denmark. You know, we are the most lucky people in the world. That's what they say. And I have to say that I'm not unhappy, but I don't know whether I'm among the most lucky people in the world. We are comparable to Houston and the surroundings in inhabitants. A monarchy with our queen and her family. The political system is democracy, and we have a multi-party parliament. But our capital is Copenhagen, and probably most of you know Copenhagen. Copenhagen, but I'm not from Copenhagen, as I'll show you. The religion is 90% Protestant. Among the famous things in Denmark are the H.C. Andersen fairy tale writer, the Little Mermaid, of course, Copenhagen, Tivoli in Copenhagen, and then of course Carlsberg. Carlsberg is a huge brewery and not only a big industry but also funding a lot of science in Denmark, which we are really proud of. Aarhus is where I'm coming from. Copenhagen is located to the eastern part of Denmark. Germany is down here. Aarhus is the second largest city in Denmark. And actually we have the largest hospital in Scandinavia, at least we're going to have, because at this point of time they are divided at different locations in town, but now we are collecting the hospital like a medical center in the northern part of Aarhus, where the Department of Cardiology already is. What is important in Denmark is that we have a very centralized system for our interventional cardiology. So we only have these 4 interventional centers doing primary PCI, and this is important when we do research because we can sort of make the research centralized, so we have quite a few patients. What we have in our department are a little more than 5,000 coronary angios per year, PCIs 2,400, and among those 600 primary PCIs. These doesn't probably impress you in the United States, but in Scandinavian relations, these are huge hospitals. So we have quite a few patients when we need to do research, and we need to do research in acute myocardial infarct patients. Also, we have a TAVI program, large electrophysiological department, other pediatric cardiology procedures, and a lot of echocardiography. So we cover the whole system and the whole area, including a transplant program as well. Our research areas is among interventional cardiology. We do quite a few stent studies. Some of you might know the dynamic studies where we compared thrombolytic therapy with primary PCI in the last part of the previous century. Our TAVI was actually developed in Denmark by one of my colleagues. I'll show him in a minute. And in Denmark we also have quite good opportunities to do epidemiological studies, because we have this unique system that every citizen in Denmark has his own centralized personalized number. So we can merge the different databases from the healthcare system, from the social system and everywhere, and do a lot of epidemiology. My area is within myocardial metabolism and cardioprotection. We have a lot of studies within pre-hospital organization and referral, cardiac imaging, all the modalities, even nowadays the hyperpolarized MRI, invasive and non-invasive electrophysiology, and of course atherosclerosis and vulnerable plaque, and I think that more you know Erling Falk, who's also in our department. These are some of the milestones, the Dynamic-II study, also our sort-out program, which is merely a comparison of the stents available on the market. We can do that because we do randomization and then we follow the patients using our epidemiological systems to watch mortality and morbidity afterwards. Our Preconditioning program and also our stent valve program, which was actually initially developed by my colleague Henning Ruud Andersen, who did his first study in the basement where he made his own valve arcs, and then he put the pig valves into it. He just went down to the slaughterhouse and mounted it and then put it into the pigs, and he also developed the catheter system. And I don't know whether anybody, if you are not cardiologist, right? No. If you go to the cardiology conferences, you would probably hear the story about Henning, because he has told that story previously, because finally his own father received one of these Edwards TAVI implants. So this is almost an emotional story. Okay, let's turn on to STEMI treatment. This is a patient with a thrombus in the right coronary artery, and as you probably all know, we do primary PCI in those patients and implant stents, and then we come up with this results. We've been doing that for years in Denmark. We have had a primary program nationwide since 1999 as a part of the Dynamic study, and after the Dynamic study it was fully implemented everywhere. When we did this study, we also did some research on patients with myocardial infarction, and this is one of the things that made us wonder at those early days. This is 4 STEMI patients that had an occluded coronary artery on the right side, as I showed you. They had the same symptom duration, they had the same admission delay, and they all underwent a successful primary PCI with TIMI-3 flow. But look at the outcome of these patients. The final infarct size varied from 5% to 50% when we did some sub-studies during the Dynamic trials, where we made scintigraphic studies of the myocardial infarct size. And that made us wonder what determined the final infarct size in those patients, because they were quite alike. And even though they were similar, those patients, they came out with different final infarct size. So we thought, of course, plumbers as we are, being primary PCI operators, it might be something that we did insufficiently when we did the procedure. It was probably a matter of impaired microcirculation, which is a predictor of prognosis, left ventricular function, and of course survival. So what we thought initially was that we needed to extend and improve our interventional procedure. And I will illustrate that with this patient who has a thrombus in the proximal part of the right coronary artery. And when you see here, we inject the contrast, the thrombus just embolizes. This is the best example that I have among my patients, but it's very illustrative seeing it here. So we thought, we are giving antiplating agents, we are giving coronary vasodilators, we are giving the patient statins, but how should we then protect against microembolization and microinfarction? Oh, sorry. We know that the incidence of no flow or slow flow is quite low nowadays when we start, and we do that in Denmark when we start the antithrombotic therapy already in the ambulances. It's very low, but we also know that if we have impaired flow, it actually increases the risk of in-hospital mortality. So we thought it might be a good idea in these early days to do thrombectomy as a routine procedure in these patients. And we did that with the equipment available at that point of time, and this was the rescue catheter control system with a rather bulky catheter to evacuate the thrombus. And when we did that study back in 2005 and 6, we actually found that routine thrombectomy did not increase myocardial salvage, which we measured by SPECT, injecting the SPECT isotope before we opened the coronary artery, and then characterized the area at risk. And then after 30 days, another SPECT where we determined the final infarct size, and then we were able to calculate the myocardial salvage. And as you can see here, there's no difference between thrombectomy and standard therapy, and also final infarct size actually increased in the thrombectomy group. So it might even be harmful to do thrombectomy in these patients. This was, I think, one of the early studies, and nowadays the new TASTE trial came out last year, just verifying these initial findings, now measuring mortality. More than 7,000 patients randomized, and no difference in mortality after 1 year, not after 30 days, and also not after 1 year as it was published this year. So I think this showed us that this might not be the way to proceed. So what determines the myocardial infarct size? Yes, of course, the area at risk, the location of the thrombus. The more proximal, the larger the area at risk, and the larger the risk of a large final myocardial infarct size. Also ischemia duration, of course. Also residual perfusion of the area at risk by collaterals, and to some extent, but only to a minor extent, the systemic hemodynamics. So what we have established in Denmark is recognizing that treatment of a myocardial infarction is a chain of efforts that needs to be initiated. And what we have done in Denmark, which is quite different from the United States, I guess that in the United States most people come to the hospital by themselves or call 911 or how does it? Ambulance, they do. In Denmark, every citizen knows that when he gets chest pains, he should call 911. And then we have physician-equipped ambulances, we have helicopter services, so we can admit our patients to those 4 centralized heart centers very, very quickly. And I think that we have done a lot of studies about that, and we have shown how we can improve mortality over years by the introduction of this system. The next crucial point is, of course, to perform the best interventional procedure, and that includes not only to do a good primary PCI and have skilled operators, it also includes effective antiplatelet therapy, effective antithrombotic therapy, in some cases thrombectomy, but not on a routine basis, and in some cases distal protection, but not on a routine basis. We have also implemented that because we have rather few but skilled operators, and we have in the pre-hospital system the possibility to start the initial treatment on site, starting the antiplatelet therapy, starting the antithrombotic therapy already on site or in the ambulance. So I think that those 2 first part of the chain has actually been achieved in Denmark. So what is left? Left is myocardial infarction with reperfusion and reperfusion damage. And the reperfusion damage is actually the injury that takes place when you open the coronary artery. A lot of scavengers are released, a lot of rust products are released, and that might add to the ischemic injury, and that conforms the reperfusion injury. Of course, if you don't do anything, you will get an even larger infarct. But this part is actually potentially salvageable. And if you want to see examples, you can see here examples from PIC studies that we have done. Normal myocardium, 45 minutes of ischemia with swelling of the mitochondria and lipid droplets, 90 minutes of ischemia, and dissolution of the myocardial fibers or the muscle fibers if you have no reperfusion. But watch this picture here. If you have 90 minutes of ischemia and 1 minute of reperfusion, you can recognize the explosion that takes place when you do the reperfusion. So it's really something that might be of potential clinical importance. But why is it important? Because if we have also watched how mortality develops in patients with acute myocardial infarction over 25 years. We have done that in Denmark. And as you can see here, in men and women, the acute mortality actually decreases quite dramatically after we have introduced better treatment. But what you will also notice is that the subsequent improvement in mortality is far less, meaning that we have become very good at doing acute treatment of those patients, but there's still something to do for the patients on a longer perspective, and that is predominantly due to heart failure. And you can see that from this study in the United States, where an epidemiological study looked at the heart failure hospitalization after first-time myocardial infarction. And you can see here that the heart failure hospitalization does not decrease dramatically, even though over the years treatment has improved. And also mortality of heart failure does not improve dramatically over the years in the United States. And I guess the United States and Denmark are quite comparable. And when we did the same study in Denmark, we were able to show actually the same things. Just over the last few years, a modest decrement in hospitalization and a modest decrement in mortality. So this makes the concept of cardioprotection relevant. And does it occur in patients? Yeah, it might occur in patients, because it might be the explanation to different treatment results in similar patients that I showed you. Because it seems as if some patients have the ability to activate their own endogenous cardioprotective mechanisms. For instance, in patients that develop pre-infarct angina, as I'll show you, they actually have more salvage and smaller infarct size. So the question is, can endogenous cardioprotection actually be activated? And we know it can be activated, for instance, by exercise, and we also know that it can be activated by the different conditioning methods, pre- and post-conditioning, and the area which I'm most interested in, remote conditioning. This is an example from our own experimental lab where we sort of trained rats and perfused the rat hearts after training in a Langendorf model, and then introduced global ischemia. And here you can see the comparison with those rats that were exposed to exercise compared to those without exercise. A dramatic reduction in myocardial infarct size. The white area are infarct sizes.
How long was the exercise? This is the aerobic exercise over a period of how long?
If you promise not to tell me to tell the ethics committee, it was actually 1 hour.
One hour running on treadmill?
Yeah, it was.
For how long? How duration in terms of?
Yeah, we had different. We have low and we had high intensity of those. And when we had the high intensity, I don't remember the exact vat, but these were really such that when we finished, the rat would go off the treadmill. But we could see a dose dependency when we looked at the moderate and intense intensity of the training. I also have to say that this was actually delayed preconditioning, because when we have preconditioning, you have a first window of protection which lasts up to 2 hours, then you have a free period, and then after 24 hours you have the second window of protection. This was actually the second window of protection we studied here. When we translate that into a clinical situation, we also looked in patients that came in and then we measured the myocardial salvage index using MRI, area at risk using the edema, and you can question whether this is correct, and we could discuss that. But we used that, and when we looked at the salvage index here and compared those patients that had no pre-infarction angina with those with pre-infarction angina, you could see that the salvage index was actually higher in those patients. And we also did studies where we used another model, because when you have a cardioprotective mechanism, this mechanism is actually cross-species transferable, meaning that you can do remote conditioning in a human, then you can take out plasma, you can make a dialysate out of it, and then you can transfer it to a Langendorf model using a rabbit heart. Not a rat heart, but a rabbit heart or mice heart. I don't know why we couldn't do that for rats, but we could do for rabbits and for mice, but not for rats. So we used the rabbit model here in a Langendorf system, and we took healthy volunteers, and we took patients and did the remote conditioning procedure, 5 minutes of occlusion of the upper arm, release for 5 minutes, and then repeated this procedure for 4 times. And then we took out dialysate before and after and transferred it to this Langendorf model of the rabbit heart, which we exposed to ischemia. And then you could see remote ischemic conditioning, reduced infarct size. And when we did the same, doing exercise on a on a bicycle test, we were actually able to show the same kind of protection. So
just one-time exercise in bicycles, or
yeah,
regular?
We actually exercised those young people as much as they could until they reached the wall. And they really exercised. And when we measured their lactate concentrations, circulating lactates, it was between 14 and 16. So they were really exercised.
But only one time?
Only one time.
Right after the exercise?
Yeah, and
blood,
so this is the immediate effect. Yeah. Cardioprotection with remote ischemic conditioning and with exercise. We also did some other studies here where we are actually able to block, or at least partially block, the effect using naloxone, as we saw last Sunday when we had another meeting. So opioids are somehow involved.
How long after did you do the measurement? You're looking at the blood. How long after the exercise did you do that?
We took out the plasma immediately after, within 5 minutes.
Oh, very nice.
Yeah.
The effect that you were showing with exercise is with the higher intensity exercises, is that correct?
Yeah.
Did you see it the same level of protection with low intensity exercise?
We haven't done that study, but as you know, others have done similar studies showing that low exercise might provide the same efficacy. And also in swimmers, for instance, as we saw last Sunday, this was actually a modality that could increase endurance of swimming. So some sort of protection. This is the protection. This is one thing. The other thing is endurance training, or I don't know whether runners, swimmers. They can do more when they are trained and when they are exposed to remote ischemic conditioning. From the clinical situation, we also have quite a good opportunity to watch what's happening in patients, because in our hospital system, or in our pre-hospital system, we have the possibility to take continuous ECG in the ambulances, meaning that we can take ECG on site to the right part. And this is, of course, the index ECG, and these are also patients, all are patients that have a ST elevation myocardial infarction. So, of course, they all have on site, when the ambulances reaches the patients, they have ST segment elevation. Then, during transportation, or when they arrive at the cath lab, they might have continuous ST segment elevation, or they might have dynamic ST segment elevation. That's how the patients present, and I guess that it represents that the coronary artery opens and closes. So if we look at these patients here, you can see one group of patients have ST segment elevation on site when they come to the cath lab normalized. When we do the primary PCI, it goes as it should and still normalized, and they have normalized their ECG after the primary PCI procedure. This means 90 minutes after the primary PCI. When we do look at the simultaneous SPECT scan, we have also measured area at risk in those patients, and you can see here those patients in group A have an area at risk, but it's not that large. But what is important is that when we look at the final infarct size after 30 days, they do not have any final infarct size. These are probably patients that open and closes during transportation to primary PCI, meaning that they have some sort of cardioprotection, or they only have very short-lasting occlusion of the coronary arteries. The other group of patients here, group B, are patients that have the ST segment elevation on site, arrive at the cath lab with normalization of the ECG. They are not many patients, but these are the patients that are exposed to severe ischemia during the procedure. And then they almost normalizes afterwards. But they have an area at risk. But even though they are exposed to rather severe ischemia during the procedure, they come up without any final infarct size, meaning that they might also have preconditioned themselves. These are the most common patients, of course. ST segment elevation on site, on arrival, uncomplicated primary PCI, normalization of ECG, quite a large area at risk, and not so big final infarct size. And these are the patients where everything goes wrong. ST segment elevation on site, on arrival, even during the primary PCI, and no sufficient reperfusion, so they come up with persistent ST segment elevation. They come out with a huge area at risk and a rather large infarct size, no cardioprotection. This might reflect naturally occurring cardioprotection.
How often do you think that autothrombolysis happening, like the intervals, 10 minutes, 30 minutes, it's 2 hours? In the labs, we see every 15 minutes.
Yeah.
It cleans up and then it starts plugging up platelets. And
yeah, those were short-lasting, I have to admit, because you normally finish your procedure within 15, 20 minutes, something. But even so, they have been exposed to ischemia. It does occur.
Yeah.
If you look at some epidemiological data, recent data from the UK were published in the European Heart Journal this early fall, and here they compared patients on an epidemiological basis, where they looked at the mortality depending on whether the patient had existing pre-ischemic heart disease prior to their first myocardial infarction, ST segment elevation infarction, whether they had no prior ischemic presentations or whether they had prior presentations, new prior presentations immediately before the first acute myocardial infarction. And as you can see here, those patients that had existing ischemic heart disease had the highest mortality. Those who came in with an acute myocardial infarction, ST elevation, without prior ischemic presentations, had a mortality here after 7 days of approximately 20%, quite high compared to Danish conditions, but these are the results. Those with preceding ischemic presentations in the form of unstable angina had lower mortality. And not only that, but also mortality was dependent on the occurrence in relation to time before before the acute myocardial infarction. So those with prior manifestations of unstable angina within 1 to 2 days have the lowest, those without had the highest, and then in between in a dose response dependent manner. That might also reflect endogenous cardioprotection. We found exactly the same in our patients where we did the same study, lowest mortality in those patients with previous angina and those presenting with symptoms within the 7 days before their first myocardial infarction. So it seems that in every biological body there is some sort of potential cardioprotective mechanisms that can be activated. And how can we activate them? There are several methods, pharmacological methods. I won't say too much about it, but it's well known that cyclosporin, GLP-1 analogs, beta blockers can introduce cardioprotection. Also, mild hypothermia, cooling, can to some extent do that. The most recent study was the CHILL trial, showing that in large anterior infarcts there was some cardioprotective effect of cooling. For both pharmacological and mild hypothermia, it is necessary that either cooling or the pharmacological agent is on board before opening the coronary artery. So you need to add the cyclosporin, the GLP-1 analog, or the beta blocker before you open the coronary artery. You need to cool down centrally the heart before you open the coronary artery to gain any effect of these modalities. And this is not always what you like to do when you are a primary PCI operator, because you think, and I think it's correct, that you should open the coronary artery as quickly as possible.
So what about aspirin?
Pardon?
Aspirin, you know, I mean, they say, you know, you have a heart attack, make a dose of aspirin.
Yeah, but that doesn't provide you any, as far as I know, it doesn't provide you any cardioprotective mechanism in itself to the myocardium. Of course, it prevents further thrombogenicity.
Yeah, it's just blood thinning.
Yeah, but it doesn't protect the myocardium. These are two different things. So we have to go on to post-conditioning, and post-conditioning is the method I'll tell you about in a minute, where you open the coronary artery, and immediately after opening the coronary artery, you re-occlude the artery with the balloon that you used for the primary PCI, and you would do that within a half or 1 minute, and then repeat occlusion for 30 seconds, 1 minute, and repeat that for 4 times. And that has been shown to reduce infarct size in almost all studies. Quite a few studies recently actually could not demonstrate that, and if you look at clinical outcome, it seems as if it doesn't translate into improved clinical outcome. The other thing is remote conditioning, which I've been using. I'll show you about it in a minute. Intermittent coronary occlusion is a sort of venous occlusion rather than arterial occlusion, and in the experimental studies it has been shown that it could be used. Also, cyber-saturated oxygen and prevention of distal embolization could be considered cardioprotective.
Comment on those 5 and 6. Do we really have evidence that
No,
reaches?
we don't have evidence, and we even don't have evidence for this either on a routine basis. So we are looking at these. And cardioprotection by ischemic preconditioning is the modality where you sort of warm up the myocardium with ischemia and reperfusion. And you can do that, and it was initially done by Murray and Jennings and Reimer in the 60s by occluding the coronary artery prior to sustained ischemia, and it seemed as if it was possible to modify reperfusion so that the tissue damage that would take place after ischemia and reperfusion would actually be decreased. And this modality, which was shown on an experimental basis, was quite quickly translated into the clinical situation during coronary bypass surgery, where Yellen and Dutch showed that intermittent coarse aortic occlusion would actually reduce ischemic marker release after the bypass surgery. This was extended by Karen Pröskling and Botker, showing that in the heart, if you occlude the circumflex artery and then make a sustained occlusion of the LAD artery, you could actually reduce the infarct size in the LAD area by the intermittent occlusion of the circumflex. So this is in-organ remote conditioning. And this was what was translated into a more useful model using a distant remote where you used another organ to provide cardioprotection by occluding the upper limb, or in the experimental setting where we used pigs in our model, the hind limb, by introducing 3 or 5 cycles of 5 minutes of limb ischemia, and that could actually reduce infarct size. We showed that together with Raj Kabanda in an experimental pig model, and it was also translated into a human forearm model showing that the ischemic damage that could be introduced by occlusion of a upper arm, that would introduce ischemic damage of the endothelium. But if you used remote ischemic conditioning on the contralateral arm, you were actually able to at least attenuate.
How much was that the attenuation that you would consider significant?
It was significant, but I think it was modest, to be honest and sure here. But it was actually the first demonstration that this model could be translated from an experimental model to a human model.
And you said also something about 3 times versus 4 times.
Yeah.
Did you compare twice, 3 times,
No.
4 times?
No. Yeah, we did compare, but initially it was on an empirical basis that they used 4 times, and then for practical reasons, I guess it was, they used only 3 times in the initial not remote conditioning but preconditioning studies during CABG surgery. And I think that's why there's no agreement whether it should be 3 or 4 cycles that should be introduced. And these are empirical. We have done studies in mice, but not in humans. In mice, where we have demonstrated that if you go up to 4 cycles, you won't gain anything going up further. After 4. So it seems as if you reach a saturation at approximately 4. But if you extend the periods to 10 minutes, actually the efficacy goes down again.
Yeah.
Yeah.
How about like between 2 minutes occlusion, 3 minutes occlusion, 4 minutes, and 5?
Yeah.
I know you've done some studies.
Yeah.
How do we come to that magic 5-minute number?
Empirical. From the beginning, it was empirical. Now we have demonstrated that if you go above 3 minutes, you actually don't reach anymore.
If you go more than 3 minutes, there's not incremental value.
No. In a mice model. I don't know in a human model.
We don't have any human.
We don't have in human level.
3, 4, 5 minutes in terms of outcome.
No. We have also compared, and this is a common question, do you gain anything by occluding 2 limbs compared to 1 limb? And you don't.
Yeah.
At least not in the mice model. We compared 1 and 2 hind limb occlusion, make no difference. Another important thing is that to introduce this concept of ischemic conditioning, you don't require ischemia. Also pain by acupuncture can actually introduce it, and also capsaicin, a medicament that...
For your studies with 1 arm in UT Austin, we could not see the effect. We had to do both arms.
Okay.
For athletes, there are young athletes, we were
Yeah.
trying to look at
Yeah.
So there is some dose effect
Yeah.
in terms of the amount of tissue being ischemic condition and whatever is released that we don't know.
Yeah.
And the neurological effect.
Yeah, we didn't see that in the mice model at least. But the challenge, of course, is when you have predictable ischemia, you can do preconditioning, But if you have unpredictable, and this is the most common thing that you have when you have a heart attack, which is unpredictable, then you cannot use preconditioning when you introduce the stimulus before ischemia. So you need to do something either during ischemia or after ischemia. And as I said before, if you use drugs, you need to have it on board before reperfusion. If you use hypothermia, which is not so convincing, but if you use it, you also need to have cooled down the heart before reperfusion. Or you can choose post-conditioning, or you can choose remote conditioning, because the advantage by remote conditioning is that you can move the stimulus from the period before ischemia to the period during ischemia. And then we chose to call it preconditioning, because then you have pre, post and preconditioning. But nowadays it's mostly called remote conditioning.
Could you say us about the period of how long the effect lasts? In other words, when you do the conditioning, what's the protective period subsequent to the conditioning? How many days?
Yeah. First window 2 hours. Then there's a period from 2 to 3 hours up to 24 hours until the second window of protection appears, and the second window of protection seems to last a couple of days. So I'll show you if you can combine it.
So you don't have a heart attack after between 2 hours?
You shouldn't. You shouldn't. Or you should repeat the procedure. That's the important thing. But what we did in our study was to use an ordinary blood pressure cuff during transportation to primary PCI, and we inflated for 5 minutes, deflated for 5 minutes, and repeated the procedure 4 times. And we could do that in the majority of our patients because we have the long referral period from the rather big catchment area that we cover. But of course, if the patient came in from just outside the hospital, which was rather uncommon, we had 333 patients in our study, and only 16 patients did not have the full 4-cycle period. We only had 16 patients that only had 3 cycles. But we just continued at the cath lab. But we had 16 patients, and we couldn't see any difference between them. But these data are not so valid because the power is not so strong. But this is the way we did it. Before we did it in patients, we did a pig study where we used preconditioning and studied whether we could reduce infarct size, and actually we were able to demonstrate that infarct size was reduced as much with preconditioning as with preconditioning. So you can do it during ongoing ischemia. And then we translated it into the clinical situation where we applied remote ischemic conditioning during ambulance transport in patients with STEMI to primary PCI. We measured salvage using SPECT. Prior to opening of the coronary artery, we injected the isotope. Within 8 hours, we established the area at risk. After 30 days, we did the final infarct size, and then we calculated the salvage index. And as you can see, we could demonstrate that the salvage index increased from 55% to 75% overall. We were also able to demonstrate that the efficacy was dependent on infarct location and on vessel patency, meaning that those patients with large anterior myocardial infarcts, LAD infarcts, actually had the most pronounced reduction of final infarct size, which is here in percentage of the left ventricle. You can also notice that in those patients with non-LAD infarctions, which are quite commonly not the largest infarct, although you can have a large right coronary infarct, but these infarcts were pretty small with effective primary PCI. And we could see that those patients that had occluded vessels on arrival actually had the most pronounced reduction in final infarct size, whereas those with non-occluded coronary arteries actually had quite small infarcts. We were able to translate that into an improvement in those patients which were most severely affected, and that means those patients with a large anterior infarct, where we measured EF by echocardiography and by MUGA after 30 days, and we could see an improvement in left ventricular ejection fraction in both parts. We then did a follow-up of the patients, although our study was not powered to establish whether there was a clinical benefit in our patients. But we did that by following our patient up to 4 years, and we calculated the major adverse coronary and cerebral events in those patients, and those that received preconditioning in addition to primary PCI actually had a lower event rate than those that had standard therapy. Again, we need to confirm this in a larger study, because this is not a study that was powered to clinical endpoint.
SPECT imaging, did you show any changes in enzymes?
Yeah,
Troponin levels?
but not significantly.
Really?
Yeah,
How could
but many other studies have shown that.
that the effect was
There was a trend, but the inter-individual viability is huge. So I was just wondering why that others have been able to demonstrate so large difference.
Does that argue that the effect was sort of after the injury? It's not really, we couldn't control the injury because the injury was already ongoing?
Yeah, I don't know, but the thing is that you have a huge range of release and, in fact, ischemic marker release. So I think that to really rely on these data, you need to have the area at risk to determine the degree of salvage in terms of salvage index. I think that is much better. But I can see that many studies have shown efficacy using the ischemic markers. We were not able to demonstrate a significant reduction, but the majority of studies that have used ischemic markers have been CABG studies or surgery studies, where the release is not that pronounced that it might be in patients with acute myocardial infarction.
But your EF showed improvement, ejection fraction.
Yeah.
And that's, you rely on that one, is that in your evaluation of dispersion and variance?
Yeah, but also these are only the patients with the large anterior myocardial infarction. Those patients with non-anterior myocardial infarction actually did not have reduced EF, so it would be very difficult to show an improvement. So these are the most severely affected patients. And this is the individual components of the outcome, all-cause mortality, which was actually statistically significant, but again, not powered for that, while the others showed the same trend, but with a large confidence interval, because the study was not powered for that. And I also have to say, when we look at, I didn't bring that, when we look at the mortality and we divide it into cardiac mortality and non-cardiac mortality, we noticed that cardiac mortality was seen initially within the first 15 months, but even after 15 months there was a difference. They still separated, and that was actually due to a difference in cancer death. And I don't say or don't claim that cardiac remote conditioning prevents cancer. So
it prevention or was increased?
No, the reduction. Yeah. So it just emphasizes that we need a larger multi-center study to clarify that, because our study was not powered to that.
Excuse me, did the patients who had decreased, the groups that had decreased mortality, did they match the ones that had higher salvage index?
Yeah.
So
Yeah, sure.
predictor, you know, where it's
Yeah, and also we just presented from our data at the HA meeting when we looked at the salvage index compared to the delay in healthcare system. Of course, the longer delay, the lower the salvage index, and these are the control patients. But actually, the curve goes up here, so it seems as if you might be able to open the window for doing primary PCI when you use remote ischemic conditioning.
What was your average ambulance time there for traffic?
You can see here, 100 minutes, 200 minutes, 300 minutes. We actually have few patients that come up to more than 200. The majority would lie, but not all patients, within 120 minutes, which is the requirement. But it also depends on how you define the healthcare system delay. Sometimes you define it as a 911 call, others as the time for the first ECG. And in Denmark we use the 911 call because it's always fixed and you can't cheat with it because it's when it is the ECG you can take that 5 minutes before or later. So perhaps you could open the window for doing primary PCI using remote conditioning.
So your conclusion, I know your paper in Chicago, your conclusion was that by doing ischemic conditioning you can buy time.
Yeah.
And buy muscle.
Seems so. Also, all the studies that I have shown are from primary PCI. And quite recently, Jelland and Hausenloy did a study on Mauritius, which is a island in the eastern part of Africa, an island with a multi-ethnic developing country, multi-center with 5 hospitals. They included 520 patients. They did RIG in the same manner as we did, and they added it to thrombolysis rather than primary PCI because they don't have a primary program. And they even have quite a bit of comorbidity, 40% diabetic, 40% hypertensive, and less than 12% in the circumflex artery. They showed that RIG reduced myocardial infarct size as measured by troponins and CK-MB in that study. So it seems that it is not only in primary PCI, but also in thrombolytically treated myocardial ST elevation myocardial infarction that remote conditioning might be effective.
Was this done in the ambulances as well?
No, that was done on admission to the hospital, yeah.
Are you going to tell us about diabetic patients? And
I could. I just wanted to summarize what we have of studies now in remote conditioning in STEMI patients. We now have 9 studies, and I have to admit that these 3 are our own studies. So these are actually the same patients, but in 7 studies then consistently show a reduction using different outcome measures, but an improvement using remote ischemic conditioning. Please?
Do we know if the magnitude of cardioprotection decreases with subsequent treatments, or is it consistent?
Yeah, in terms of reduction of myocardial infarct size, yeah, 30%. We found 30% using infarct size reduction as a measure.
So does the body generate the same amount of cardioprotection mechanism every time you do it, or till you die, or does it?
I don't know. These were first-time myocardial infarcts. Yeah, and I think that all studies that have been conducted until now have been in first-time myocardial infarcts. Our ongoing study now, which is in 4,000 patients, also take patients with previous myocardial infarctions into the study. The reason why we used only first-time myocardial infarction was that we used SPECT as the primary outcome. And to use SPECT, you need to define the final infarct size. And SPECT doesn't distinguish between a previous myocardial infarct or a current myocardial infarct. So we needed to include only first-time myocardial infarct.
If I can add to Hader's question, so if we consider ischemic conditioning, one cycle, which is say four treatments, 5 minutes each. If we consider that one bolus of injection of a cocktail, perhaps the question is, how often do you have to do that? Is it a once a week drug? It's a once every 3 days? And whether our body gets used to it, and or it's like a statin that you have to take to maintain your cholesterol level?
I think that previously we thought that this might be a one-time use in a situation where the body was exposed to a challenge. But it seems as if you can add something to it, at least in the experimental studies. You know, Andrew Reddington did a study where he studied rats, and he did preconditioning, and then he combined it with post-conditioning for 30 days. And then he looked at myocardial infarct size in those different groups, and he did it in the way that he did per-conditioning, and then he did post-conditioning every day and post-conditioning every third day. And he was not able to demonstrate a further reduction in infarct size. But in the group of rats where he studied survival, he was actually able to demonstrate that survival improved in those exposed to per-conditioning plus post-conditioning every day and every third day, and per-conditioning compared to the controls, and in a dose-dependent manner. So it seems as if there might be some protective mechanism beyond just infarct size reduction.
So I was getting at this is a simple procedure if I do it every day, because I can't predict when I have a heart attack. When I do actually have a heart attack, I reap the benefit.
I don't know whether that should be, because the other thing that what made me hesitant to recommend that would be that patients with diabetes, as Morten already mentioned, patients with diabetes seems to have this system activated inherently. So if you have diabetic animals comparing with non-diabetic animals, the reduction in infarct size is lower in diabetic animals. And these are diabetic animals that don't have atherosclerosis and other comorbidities. So this is a pure diabetic model. But they have smaller infarcts than non-diabetics, but they don't have any effect of remote conditioning. So it seems as if you have already activated the system and then you come into a challenging situation, you're not able to activate it further. But I don't know whether it's that firm to claim that, because it seems in other situations as if you can get some benefit beyond infarct size reduction.
So are you saying diabetic patients are already ischemic conditioned somehow,
inherently,
some pathway, or they have some mechanisms that resist ischemic conditioning?
I don't say that they are already. I don't say that patients are already, but I think that in experimental animal models they are. But in patients it might be different, because they have atherosclerosis, they might have hypertension, they might have other things. So I don't think I can answer that. I can answer that when we looked at this, and I come to this now, because also remote conditioning has been conducted not only in ST segment elevation, but also in CABG surgery and other forms of cardiac surgery where CABG were combined with valvular surgery. And the majority of the studies have demonstrated a beneficial effect, but not all of them. And what could that be? There are some challenges in translation. It is quite easy to demonstrate that this modality works in an experimental model. Where you have a healthy experimental animal, then you can show it works. But when you go from the healthy experimental animal to patients, the thing that you already said more about the diabetes, hypertension, co-medication, etc., actually might challenge the translation of benefit into patients, because patients are heterogeneous, and we also have to remember that patients do not have normal coronary arteries that the animal models have. When you have the animal models and you sort of release the stenosis, you have a burst of reperfusion. In the patient, you might have reperfusion through residual stenosis, which might be much more gentle, and it might be what you, for instance, do by post-conditioning, sort of inducing gentle reperfusion. You also might have some microembolization that makes it impossible to have some infarct size reduction. The area at risk might vary, the timing of reperfusion, age. We know that increasing age induces loss of cardioprotective signaling systems. We know that the comorbidity, as we already said, diabetes, hypertension, hypercholesterolemia. We know that some medication actually in itself has cardioprotective mechanisms like metformin, whereas sulfonylureas actually work the opposite way. Opioids also have some cardioprotective mechanisms, and also like the beta blockers, statins, we don't know about ACE inhibitors, AT2 blockers, nitroglycerin, but adenosine certainly have. So it is a challenge to go from the healthy experimental animal to the clinical situation.
Are there any experiments done with like apoe mice or hypercholesterolemic pigs or something to get unhealthy animals, whether they really have the disease rather than just having it artificially?
Yeah, but I don't know whether studies have been done but we looked also in our population in the first study, looking at any modification by risk factors, and we looked at age, we looked at gender, smoking, body mass, diabetes, hypertension, left ventricular hypertrophy, and as you can see here, it seemed as if remote conditioning works in all of them except in smokers. And that might be an issue for those interested in NO, I would say. But I also have to admit, again, the power of the study was not sufficient, and also that when you look at diabetes, many of those patients were on treatment either with sulfonylureas or with metformin. So whether this represents the disease itself or whether it represents the treatment, we don't know. We also looked at the effect of cholesterol, LDL cholesterol and plasma glucose, and we didn't find any effect that modified. And also when we looked at the co-medication, and this was the co-medication that the patients were on before they came to the hospital. Beta blockers didn't attenuate the effect, ACE inhibitors, calcium antagonists, and statins.
Looking at the actual data, do you see any evidence like of responder versus non-responder? Like complete disparity between the groups?
Yeah, but we haven't been looking at it in that way, because of course there are some patients that don't respond. But we haven't, I don't know whether there are non-responders or whether this non-respond is perhaps because they are smokers. So it might be those confounding factors that could explain that. Now we come to the things that we have already been discussed, because this is what you asked about, the combination of remote conditioning as remote preconditioning and combination with post-conditioning. There has been another study by Andrew Reddington's group where he combined, and as you can see here, if you combined post-conditioning with different intensities of per-conditioning, you would see that if you combine post-conditioning with per-conditioning in 4 times 5 minutes, you have a small further infarct size reduction. And they concluded in that study that there was a dose-dependent additive effect in the experimental setting. Well, I'll let you judge yourself. I'm not that convinced, I have to say. And at least if you go to the clinical situation and you combine remote ischemic conditioning with post-conditioning, Prunia's group here were not able to demonstrate any additive effect on either CKMB area under the curve or peak CKMB. So I think in a clinical situation, it seems as if the combination of remote conditioning and local post-conditioning by reinflation of the balloon does not add any additive effect.
So this was cath lab based, so...
This was cath lab based. This
come here, open it, close it 1 minute,
yeah.
open it again, close it 1 minute.
This was cath lab based.
And then add an ischemic conditioning after that or before? The remote ischemic conditioning?
That was before.
Before.
Yeah. And this is what I already showed you, or told you at least, now I can show you. These study by Reddington's group, where they combined the preconditioning with post-conditioning every third day and every day. And as you can see, no further infarct size reduction, but an improvement in survival. So that might be that there's something beyond infarct size reduction. We recently studied whether the cooling could be combined with remote ischemic conditioning. And as you can see here, we have controls here, and we have controls with standard therapy and with cooling. And cooling would reduce infarct size in this animal experimental model in the rat, where we reduces infarct size if we have cooling during the whole period of ischemia, during the last 20 minutes of ischemia, or during the whole experiment. But if we only have cooling in the reperfusion period, there's no significant reduction compared to control. But in every instance, adding remote ischemic conditioning also adds further cardioprotective mechanism. We participated in the Chile MI study, and I have to say, cooling a patient with acute myocardial infarction at the same time as you do a primary PCI, that is challenging. Yeah, you need to put in a catheter through the venous, the femoral vein, and then put it into the left atrium, the right atrium, of course, and then you need to give cool saline intravenously, and then cool saline during through the catheter that you put into the right atrium. And then you need to control that the core temperature goes down to below 34 degrees. The patient shivers and he feels uncomfortable. You need to give him anti-shivering therapy, and the effect of cooling is really marginal. So I think the future would rather point toward remote ischemic conditioning.
Do you use heating pad to warm him up against the shivering?
Pardon?
Do you use heating pad?
We put blankets. Yeah.
To warm it up against shivering.
Yeah.
So you're heating and then you're cooling.
Yeah, you're heating the core temperature. You're cooling at the core temperature, yeah. And then you're heating at the skin. That's how you do it. I didn't feel comfortable by doing it. I could see at the patient they didn't feel comfortable at receiving it. So I didn't say much about the underlying mechanism, and I don't think that I will say much about it. But where we are now is that there is a stimulus from the effector organ, and this stimulus is dependent on preserved neural pathways. But there are also humoral pathways involved, and the newer studies have shown that even exosomes and microRNA might be involved in translation of this mechanism, because then some humoral compounds are released, working at a receptor organ at a receptor in the target organ that activates intercellular pathways, that works through the mitochondria by inhibiting the opening of the mitochondrial transition permeability pores, and by modifying the opening of the mitochondrial KATP. This results in a protection that reduces myocardial infarct size, but also works through anti-inflammatory effects, and it prevents endothelial dysfunction and platelet activation.
How does that affect platelet activity and the anti-platelet effect of ischemic conditioning? How do you?
I don't know if anybody knows much about the mechanism. We have studied activation and shown that the activation is reduced in aggregability, and that's the way we studied it, and that was quite simple, I have to admit. So I think it's where we are now. There are other antiplatelet compounds like the ticagrelor, which has been demonstrated to have not only antiplatelet activity but also cardioprotective activities, and that probably works through adenosine. You know, some of the patients that receive ticagrelor also gets dyspnea due to adenosine release, and they probably receive some sort of cardioprotection through this adenosine mechanism. This is how it's thought to be.
But ischemic conditioning, the adenosine release is so fast and volatile and just goes away. The ADP, they're not long-lasting in circulation. They go forever.
No.
Right? You create it in here and then they die quickly.
I don't know anything about the mechanism. I just.
But it is. But
yeah.
It is evident.
Yeah, it is. It is.
It is.
Yeah. And also we did, when we have finished the MI study, we did a study in stroke patients, and one of the concerns in the stroke study was that if you had patients that not had a stroke on an ischemic basis but on a hemorrhagical basis, could you then worsen it for the patient doing remote ischemic conditioning due to this antiplatelet therapy thing, or therapy, or due to this antiplatelet activation. And we studied these patients selectively among those patients that we included, another 300 patients. 36 of them had hemorrhage. But there was no difference between those having remote conditioning and those that had no conditioning when we compared the size of the hemorrhage. So I think these are mechanisms that we don't know too much about yet. I think that if we should say something about the perspective is that there is a cardioprotective mechanism. There also seems to be a protective mechanism in stroke patients that receive thrombolytic therapy. But the important thing is that if you have patients, it seems as if those that benefit the most are the most severely affected patients, those with a large anterior myocardial infarction. So it could be a perspective whether remote ischemic conditioning could work not only in the heart, for instance in patients with cardiac arrest, but also in the brain in patients with cardiac arrest. It hasn't been studied on a clinical basis yet, but it has been studied in a rat study which was recently published, and there are quite a few others, but they are quite consistently demonstrating that if you have a model where you have rats exposed to ventricular fibrillation in this situation for 6 minutes, and then the patients were exposed to CP resuscitation for 8 minutes, and then they were divided into 3 groups: remote, preconditioning, and then conditioning that were onset coincident with the CP resuscitation, and another group where the conditioning, the post-conditioning, was initiated 5 minutes after successful conditioning, resuscitation. And what you can see here is that if you look at the ejection fraction, the heart, there was an improvement with remote ischemic conditioning and with those combined with post-conditioning. And also if you look at the neural deficiency score, there was also a quite pronounced improvement. So it seems as if this is a multi-organ protective mechanism that can be induced. And of course it would be important to add remote ischemic conditioning to cardiac arrest patients. And you should add it to the standard therapy, which also now includes hypothermia in these patients.
So do you envision a day that every automatic defibrillator would have an ischemic conditioning device?
That might.
So just
That
put it
might.
on, put it on.
That might be an option. So I think I'll conclude now. Yeah. I think that remote ischemic conditioning can be translated into a clinical context of STEMI patients treated with not only primary PCI, but also thrombolysis. It seems there is a short as well as a long-term clinical benefit, and some mechanisms are discovered, and I think that the fact that we have demonstrated that this is not only some paramedic thing, but also that we can identify the mechanisms that provide the cardioprotection substantiate that this might have a clinical potential. Thank you.
This is really fascinating. And Charlie,
There are a couple of questions, I think.
Yes, go ahead.
Please.
Are there any negative or undesired effects of this treatment in the studies that, or your studies that you found?
We haven't found. We have found one patient that had a phlebitis on the arm where the patient received this, but whether that was due to the remote conditioning, I don't know. But we had to report it. Yeah, she had a phlebitis where she had a ventron into the arm. We had to report it as a side effect.
Well, yeah, but I can't see
Only
the
thing.
connection. What about bruising and all the petitio and?
No, we haven't seen that.
Really?
Of course, we don't use it for the in patients that have hemiparesis, or you need to have your full mobility, and also patients that have AV fistula for renal dialysis. You can't use it, of course.
Well, that's what I was going to ask you. Who was in your exclusion criteria? Was there more males or females in your study? Were there more females or males in your study? Was it evenly divided?
No. In our
what was in your exclusion
in our STEMI study, we had approximately 75% males, like in every STEMI study.
Yeah.
And then, like you said, your exclusion criteria was somebody who was on dialysis, or did you have anybody?
No, we didn't have any dialysis patients in it. No.
So, I mean, given the positive results of that, is Denmark now, do you have some kind of a movement to put these devices on all the ambulances?
No. We're running this larger trial with clinical outcome measures where we measure as a primary clinical outcome mortality plus readmission for heart failure within 1 year. And we're running that together with a part of Spain and a part of the UK, planning 4,000. Yeah, because that's what we, mortality went down after AMI. Initially, when I did my first power calculation, when we finished the study, we calculated that based on an event rate of 17% within the first year, we needed to include 2,300 patients. From the period when we planned the study until we started, the mortality in Denmark went down so that the event rate is now 12%, both in Denmark and the United Kingdom. So we needed to increase the number of patients to 4,000.
Presuming that the results of this study, they probably will support your initial results, would that be the basis you think in the country that would really get these devices? Is there anything else that would prevent these from being deployed in every ambulance? Or
No.
Much more widely?
I hope it will be, in case we can confirm it, but to get a level 1A in the guidelines, I think you need 2 multi-center studies, right?
2 multi-center, right.
Yeah.
Well,
So
4,000 would be really door opener. We're trying, in fact, we were talking at AHA Chicago that we should campaign to NIH and tell NIH, look, there is no big corporation, Pfizer or Boston Scientific, Medtronics are going to come fund this study because there's not, high-tech stuff in there. And so NIH should do a study like that, and with those two, this is amazing. 30% reduction doesn't even happen with a stent.
Yeah.
That's true. But
a stent doesn't have a 30% reduction in ejection fraction, improvement in ejection fraction.
I have to say I'm still humble. I mean, this was our own study, our first study, and we need to get really clinical outcome.
Data, but I'm saying if the 4,000 patients that you show, even half of what you showed in your, it's huge comparing to what you need to do, which is a thing around the arm, occlude and release during ambulance, come to the hospital and just get the rest of the treatment. So I wouldn't see any reason, especially in their country, because it's sort of a national adoption. They have 4 centers.
Yeah.
The entire country has 4 cath lab centers, right?
Yeah.
In Houston, we have 10 cath labs.
Yeah, I know.
Maybe more.
I know.
This is amazing. So obviously for you, adoption of that would be it. And congratulations to you for opening this. This was, I remember 2010, when Hans-Erik first published his data. It was on the news. It was everywhere. And they were just like, this is an amazing, a blood pressure cuff can cause a significant reduction in heart attack. We'll look forward to seeing your brainchild and all of this hard work come to work, and hopefully we'll have you here maybe in a few years.
Hopefully.
That study is scheduled for.
Yeah, we have started in 2 regions in Denmark now, 2 of the 5 regions, and in Spain, and then we need another 2 regions in Denmark, and then after New Year we'll start it in the UK. We have like 450 patients included now.
Already?
Yeah, so 4,000. Quite a way to go yet. But I mean, when we get London with us, the London area, and I think that the inclusion rate would increase.
But the outcome is mortality.
It's going to be mortality over, you're going to follow them for how long?
A year. Mortality and readmission for heart failure within a year. Okay. And of course we would follow the patient even longer for up to 5 years.
So what do you, you said, I know you mentioned you're not an expert in that particular area, but based on the people you've talked to and what you know about it, are you optimistic about getting the biochemistry of this?
No, not anymore. I don't think. when we started this, we had a collaboration with Andrew Reddington in Toronto, and he had the full Monty of biochemists helping him. This is not one single compound.
Mother Nature is a lot more complex than it. I remember in one of our focus group meeting, we invited him, and he was referring to X factor or factor X, and he wanted to solve the factor. So he gave up on solving factor X
and moved to Cincinnati.
So why not do metabolomics? Screen for thousands of
we are doing that actually, but I wouldn't tell too much about it because I have been disappointed once. So.
We actually came to this from the other. Remember, there were so many drug companies tried to nail down the pathways, drugs, and so on, couldn't replicate the Mother Nature's, and we said, well, why not just do a cuff, a simple cuff, and comment on the duration of ischemia. This is something that we internally spend a lot of time on, and that is, it's a function of the duration of the ischemia and the level of oxygen disconnect. If you put an oxygen meter in everybody's muscle, let's say here, and occlude the cuff, our tissue oxygen level does not fall at the same rate.
No.
People with lean muscle, men, their oxygen drops faster, so they get ischemia sooner and longer. Women, their oxygen drops slowly. and they don't have as much ischemia. Don't you think this is the ground for seeing heterogeneity in response, because the dose is sort of heterogeneous?
Might well be. Might well be.
That's one of the reasons probably when you do these major studies. I mean, I'm afraid this is a study that you're starting, 4,000. You give the same dose to everyone.
Mm-hmm.
What if some women don't get as much ischemia with 5 minutes, whereas some other men would get? And with 4,000, you will have the luxury of looking at subgroup analysis.
Yeah, and that's what we are aiming at.
Yeah.
Because I don't know whether, again, it's not a prerequisite that you have ischemia to have the effect. As you know, acupuncture can actually
Acupuncture. So, I mean, are you saying so we all just switch to acupuncture and start doing putting acupuncture in ambulance?
I don't know, but it seems as if it can. And capsaicin, another compound that creates pain. But it's not only pain, because also those patients that underwent remote ischemic conditioning during CABG surgery initiated the procedure after anesthesia was induced, and still an effect. So
I would find it hard to believe that it's independent of ischemia. It should be primarily a product of ischemia, but it could also be exaggerated by other things, the neuromechanisms that you're talking about, that mediates some part.
Yeah.
And the fact is,
I would still go for the ischemia model.
Exactly. Ischemia model is what you were proving and so on. Out of the ischemia components that we thought, EPO, erythropoietin, appears to be the most. Do you have any comments on that? EPO.
Yeah. But we have done studies on EPO as well, where we were not able to demonstrate cardioprotection, but we were able to demonstrate prolongation of endurance of exercise, if you know, because it's a doping stuff.
You don't need to just look at Lance Armstrong.
So, but we are not able to demonstrate any effect. But others have been. There have been other studies demonstrating that. Yeah. Please.
So you mentioned you're still humble. I was wondering what doubts or what areas you're still considering in your mind that we have some surprises. If you could give us.
I think.
What is your worry? He says,
I have one for you. The Danes eat a lot of cheese and dairy products, so maybe there's some.
So should that be a confounding factor? Or I don't know. They also smoke a lot still. So, I think that what worries me would be the translational part of it, the heterogeneity of the patient, the comorbidity, the co-medication, whether you are really able to translate this infarct size reduction into a true clinical benefit for the patient. I think that's going to be a challenge, the translational part of it. Yeah. Because treatment of acute myocardial infarction, when you have a primary program, as we have in Denmark, is actually very, very good. So you need very many patients to demonstrate further improvement.
So the ceiling of the improvement maybe is reached, and so there's not much to improve in terms of...
when we did our power calculation, we also did a separate power calculation for those patients with large anterior myocardial infarction, so that we would be able to demonstrate an improvement in that subgroup of patients independently, because you could say that those without large anterior infarct sort of pollute the results, but I mean it's too challenging to introduce this in the ambulances. You need to say that the patients that should be included are patients with large myocardial infarctions with STEMI. You can't have the paramedics to decide whether inferior shouldn't be included, anterior should only be included. We need to include everybody, and we also need to include everybody to see whether there is a true effect in beyond infarct size reduction in those other patients. So.
I admire you for bringing the infarction and acute coronary events as the front line. But really what I'm hoping in the premise of ischemic preconditioning, remote ischemic conditioning is for the wellness side.
Yeah.
For lowering blood pressure, improving endothelial function. Why not making this an endothelial dysfunction therapy? If there is, why
Could
not
be.
making it an exercise mimicking effect that build these beds that we're talking about, have these business entrepreneurs open like gym with bed, people go lie down on this and get ischemic conditioning on the way home, and then go home instead of going to gym and you get ischemic conditioning, because those are the things that if the effect is scientific, because this hopefully one day heart attack will be eradicated. And
but still, I would recommend doing your exercise.
there you go. Well, we want to come back. I think we had a great night. Thank you so much. Now it's
Sure,
time for
my
you
pleasure.
to eat, and we're gonna have talk here a little bit. Thanks everybody.
Thank you very much.
Thank you.
Please confirm.